Hello, Chris and the rest of our friends in Orlando, Florida. My name is Philip with Rultract. I'm going to go over how to set this Rultract retractor up for your resternotomy procedure on the 20th. Now, keep in mind here, I'm going to go through this relatively quickly. I'm not going to go into detail as to why I do what I'm doing. I'm just going to tell you how I do what I do, and that's what you should do. If you want details, there is a longer video that's probably 3 times longer that'll explain why we're doing things. But for now, let's just go through the setup so we understand how it's done. The first thing we're going to do is to put our table clamp on the bed rail. You're going to want to set this up at about the patient's shoulder level, maybe even a little bit higher on the shoulder. The reason is once this is on the table, if you're the first assist and you're standing here, this is going to be in the way a little bit the first time you use it. Until you get used to having it here, it is going to be in the way. So let's try to get it up near the shoulder, because we're going straight over midline trying to do a xiphoid incision. So we don't want to be too high in the bed, but we want to have it out of the way. So what you're going to do is, I would not recommend putting this over the drape. What you're going to have to do is kind of lift the drape a little bit. Chris, if you're the scrub, you could actually hold this, because this is sterile coming out of the tray, put it onto the rail, have the circulator come in, and squeeze these jaws together, again, being under the drape by this time. And then you're going to squeeze the jaws together, keep squeezing them together, don't let them go, and then turn the knob. So you want to squeeze the jaws, turn the knob. Don't put the jaws on there and turn the knob, because that will not get a uniform purchase on the rail. So go ahead and put the jaw on the top, rotate it in, like I just did, squeeze those jaws together, turn the knob, and you're going to want to tighten it as tight as you can. If you have somebody small in the OR that's doing this, you may want to have somebody bigger tighten the knob, because this needs to be tight and secure. So we're going to go ahead and tighten that into position, and then the scrub could grab it, make sure that it is secure on the rail. Next, we're going to take our top post, and you will see there are small splines cut into the bottom post here. You're going to set your top post right onto those. Make sure that it's properly seated and locked into position so it doesn't rotate. Some surgeons like to turn this a little bit. This will turn 18 degrees and lock into position. Some surgeons like to point it toward the incision. So if you want to do that, that's fine. The surgeon may not be aware that he can do that, so you may want to point it out to them during the procedure. If you're too far away from the incision, you can angle it just a little bit to get closer. Next, we're going to put our extender bar on. Now, there's a lock knob on the extender bar. You're going to want to make sure that lock knob is opened all the way. If it's not, this will not go on your top post. So go ahead and take your extender bar, slide it onto the top post, turn your lock knob all the way, and tighten it down, making sure that this piece will not fall off. Next, you're going to take your ratchet assembly. This also has a lock knob. Make sure that it's opened all the way. If it isn't, it won't go on. Now you're going to put this on with the handle going out over the patient's head and the cable part going out over the incision. Reason is, obviously, you want the cable as close to the incision as you can, and with the handle back here, it's easier for the surgeon to manipulate the handle. So go ahead and position it where you want it. There are guide marks here that you'll see. Just put it in between 2 of the guide marks. Make sure that this lock knob is locked all the way down and everything is secure. Now, I don't have a resternotomy retractor to attach to this, so we're just simply going to lower the snap clip to the incision, and your resternotomy retractor would be on this snap clip. It just snaps on. It's very self-explanatory. So I'm going to go ahead and lower it. Now, to do that, I'm going to flip the lever, which I'll show you, on the back of the gearbox, and I just lower it to the incision. I don't want to unwind it to the incision. That's not necessary, and it could cause the cable to kink. So you flip the lever and lower it to the incision. Once it's where you want it, just go ahead and turn the handle, and you'll start to retract. So that basically, well, that is the setup of the Rultract and how you're going to use it for the resternotomy retractor. One of the questions you may have is if we lifted this drape to put the clamp on. Some ORs don't want to do that. So you don't necessarily need to lift the drape. You can go under the drape, then you can just drape around it. So that's how I've seen it done in many places. Now, once we have this incision, once we're finished or we need to adjust the retractor in the incision, we need to remove it. So to do that, you're going to need to lower it. And we talked about, the surgeon said that he has used this before, excuse me, but just to refresh your memory or his memory of how this works. Okay, so when it's under load, which it is right now, in order to release it, there is a mechanical limitation in one direction, but not in the other. And it's not always going to be the same direction, but you will feel this. While it's under load, go ahead and try to turn that crank handle. You can see I can't turn it this way in this direction at all, but it does move in this direction. So I go ahead and move it in the direction it will move just a little bit, and then I flip the lever, and then I do not let go of this handle. I lower the retractor. Okay, so again, I'm going to raise it. It's under load, and I want to lower it so I can take the retractor out. I try to turn this handle. Well, in one direction, it doesn't turn at all. And in some cases, surgeons or people will panic. Well, it doesn't turn, it's stuck. That's not correct. It's just not going to turn one direction. It will turn the other. You have to find the direction it will move. So go ahead and move it just a little bit, hold the handle, flip the lever, and lower the sight. The reason you don't want to let go of that handle is the last time. Okay, so it's under load. I'm not going to hold the handle, I'm just going to flip the lever. That's what happens. Now that's exaggerated because I'm putting a lot of load on this. That wouldn't happen in the OR, but you do not want to let go of that handle so you have complete control. So that is how you set up and work the Rultract. I mentioned a lever on the back. It's pretty easy to see. The lever's here. We call that a reversing lever. Sorry for the jump cut there, but one of the things that's overlooked in an in-service and in the OR whenever we're finished using the Rultract or any table-mounted retractor is how and when to take the retractor down. So once the surgeon is finished reopening the chest, you're going to want to remove the Rultract from the field. What's important here, for me at least, is that we take it apart or take it down in pieces. I see a lot of ORs will grab the Rultract. Some will just grab it like this to take it out of the field. Well, it's heavy. It's top heavy here, so you need to be very careful if you do that. Some surgeons will actually remove it from the field, and what they do is they hold the gearbox and they hold the post, and then they'll just hand it off. So, Chris, if you're going to do that, make sure that you have a good grip on both parts of this retractor when you remove it from the field. The way that I like to see it done is to take it down in pieces. So even if it's just the rotating, the extender bar with the ratchet, you could take that off. And then of course this is a lot less heavy and cumbersome, so it can be removed as one piece. Of course you could take it apart in all pieces as well, but just be careful when you remove it from the field. Understand that there is a lot of weight behind it and it could be a little bit awkward. Once you have these pieces off, most ORs want to take this off as well because, again, this kind of is in the way and it's cumbersome for the rest of the procedure. You're going to find yourself working around it. So if possible, we would remove this from the field too, but that would depend on OR protocol. Anyway, that video was longer than I wanted it to be. Hopefully it was helpful. If you need to go into more detail with me, as I said, we can do a video conference or I can do another video that's going to be much longer.